Thank you very much, Chairman, and thank you very much for inviting me to be part of this meeting. It's always a pleasure. I'm going to talk to you about some basic anatomy and try and reveal that it's not all that basic. Let's start with the definition. It's always a good thing to do. A little bit of Latin, which is where valva comes from. It means the leaflets of a door. And as with all doors, they have to open as well as close. And in mitral valve surgery, we often forget the opening bit. The dynamic portion of diastole is terribly important. It's very easy to do a fixing posterior leaflet P2 repair, but in doing so completely screw up mitral valve and left ventricular dynamics. And I'd like you to keep your mind on that as we go through this. Now, the mitral valve is a complex and integral part of the heart. You know that. You've had it told to you many, many times. It's a vital part of ventricular integrity as well as maintaining forward flow. Don't forget, it's the valve that closes under the highest pressure too. So your valve has to be good at the end of the repair to last a long time, which you've just heard the importance of. When I was contemplating this, I started to think, well, actually the mitral valve is a machine. If you go to the Oxford English Dictionary of definition of a machine, it's an apparatus using or applying mechanical power, having several parts, each with a definite function, and together performing certain kinds of work. It's a machine. It's a machine within a machine, and the heart is a pump, and it needs the efficiency and durability for a lifelong functioning. So if you start to think a bit like this dynamic machine operating within this powerful pump, you begin to see the complexity of what we're talking about. We all understand the relationship between leaflets, cords, and papillary muscle. We have all had it hammered into us, the impact of the continuity between papillary muscle, left ventricular wall, base of the heart, and leaflets. But how many people think about left atrium? As the left atrium stretches, it gets bigger. But do you think about the next stage? Imagine an empty bucket. Pick it up, it's light. Now fill the bucket with water and pick it up. It's completely transformed. And that's what happens to the left atrium. And we're beginning to find evidence now that left atrial stretch is a progenitor of mitral regurgitation through, in one group of patients, atrial fibrillation. We just completed a study of 50 patients with type 1 regurgitation, orifice dilatation. I expected about 50% to be dead, because if it's a ventricular distension causing orifice distension, then they should follow the sort of cardiomyopathics we've been thinking about. At 5 years, all of them are alive. All of them had long-term atrial fibrillation. Just reflect on that. Now, this is the complex we're talking about. Here is the leaflets, the cords, the papillary muscles, an integral part of the ventricular wall. It's fun when you look at MRI scans to see how the papillary muscles almost float on the inner surface of the ventricle. They're part of the non-compacted part of the myocardium, and this is how they form. And one of the things I want to bring out in this talk is the impact of congenital formation, the actual formation of the valve, which really determines the function of that valve and its complexity. This is the bit you all know, the simple division into A1, A2, A3, M1, M2, M3, YM. We should call this the mural leaflet, not the posterior leaflet. It does not lie posteriorly in the human body in the normal anatomical position. This is artificial, it's useful, but it's artificial. And as you'll see later on, it's often much more complex than this. The structural relationships I'm going to run through, you know about the circumflex coronary artery, but I'll show you it's more complex than that at the moment. The coronary sinus, the atrioventricular bundle, and the aortic valve. A lot of people seem to think the aortic valve's over here. It's not. It's actually the outflow tract behind the septal portion of the mitral valve. Here is a dissection of this structure. Here's the mitral valve. Here's the aortic valve. This is the septal portion of the valve. Look how the circumflex coronary artery follows the periphery, the circumference of the valve. It's actually at risk of injury all the way down here. It may be more risk of injury at the A1, P1 complex, where you put your sutures towards the commissure, than actually further down around towards the base of the heart. Here's the atrioventricular nodal artery, and here are the leaflets in relationship to the base of the heart. If we look at it a little closer, here again you can see the root of the obtuse marginal branch of the circumflex coronary artery, and here's the AV nodal artery, and here's the aortic valve and the aortic outflow tract behind the anterior leaflet of the mitral valve. And this again is just to stress this portion of the outflow tract which the mitral valve forms part of on its ventricular surface. The fibrous structure of the heart is very important. There's a left fibrous trigone, a right fibrous trigone, which forms part of the central fibrous body. And the whole heart is hung from this central fibrous skeleton. And the left ventricular outflow tract, when the heart's working and during systole, becomes a cylinder. And that is what caused the anterior indentation, the convexity of the leaflet of the mitral valve. So any ring that you put in that has a preformed convexity actually alters the natural state of the valve. And I want to come back to that in a moment. The coronary sinus is usually quite difficult to injure, but I guess if you work at it, you can. It lies down in this area behind the P3 complex. And then if we start to look at the relationship of the aortic valve to the mitral valve, this is very, very important. Just recently, I heard of someone who had replaced the aortic valve and induced mitral regurgitation. And of course, if you pull up the aortomitral curtain too much in your sutures, you will do that. This is a fibrous continuity between aortic leaflet, the fibrous aortomitral curtain, and the anterior mitral leaflet. You need to think about that if you're doing combined surgery on the aortic and mitral valve. Let's talk now about the annulus. What do we mean by this? There is an annulus in the sense of a circumferential boundary to the mitral valve, its orifice, of course. There is, however, no complete fibrous tissue encircling the valve in most patients. And the importance of this is not giving people, surgeons, us, a false sense of security when we're placing our sutures in the annulus with the damage that we can cause. When you're placing your sutures, have your needle at right angles to the tissues and go down into the ventricular tissue. You will never have a problem like that. If you put it tangentially into the atrium and so forth, you will, because there is no fibrous ring, particularly from mid-P2 on to P3 and A3, to support your sutures. And a ring dehiscence is much more of a problem than people think, giving rise to recurrent regurgitation, especially in situations of high tension like ischemic heart disease and cardiomyopathy. This paper will prove the lie to all of this. I would ask you all to read it, a very good analysis of the fibrous tissue around the orifice of the mitral valve. The annular motion, we all pay lip service to this. So you have this wonderful conundrum. We all know the annulus moves, and I'll show you it moves a lot in a moment in many planes. And then we all go and fix it, don't we? So we learned the annulus is such a terribly important dynamic structure. We're even taught that the mitral valve is rather like pulling your trousers up over your bum with a column of blood going down from the atrium to the ventricle. It's all terribly important. But then we shut that door and we put a ring in. Interesting, isn't it, how we decide to do these things? It has circumferential alteration in dimensions by up to 40%. It descends apex to base. It rotates the ventricular torque. It folds and molds in a three-dimensional conventional way, the so-called saddle shape. And rings inhibit all of this motion. The ones that don't, least, are the flexible rings, but even they do too. This is an old slide just showing you the difference in circumferential diameter through diastole and systole. It is a hugely dynamic structure. So it's no good me standing here giving you a lecture on the importance of functional integrity of the mitral valve if we're just going to ignore this. This is from a recent paper, Levac and co., just showing the immensely complex movement of this structure. This valve is changing in shape and form throughout the cardiac cycle. The measurements, I don't expect you to read them all or take them in, but you see annular height to septal lateral dimension versus transverse dimensions are very different, it's 2 to 1. Annular height is in millimeters, and this is the movement in the height of the annular plane through some of this motion I've just shown you. The change in surface area and so on, which is different when measured by 2D and 3D because of the complexity of the motion of this structure. The fibrous trigones I've illustrated to you, and the extent of the fibrous continuity in the so-called annulus is about to here if you're lucky. In a few, you get little islands of it further around, but that's about it. The rest is just a junction of leaflet, atrial tissue, ventricular tissue with the fat behind. Now, when you're putting your sutures out at the P3, A3 commissure, here is the central fibrous body, but look what's right behind it, the penetrating atrioventricular bundle. And this is why the use of pacemaker in mitral valve surgery in people, well, anybody, but it can happen to anybody, but inexperienced surgeons can be quite high. You've got to really remember that when you're putting your trigonal suture for the ring. And this is just to emphasize the relationship of the anterior leaflet of the mitral valve to the outflow tract. The outflow tract forms a cylinder, and the anterior leaflet is simply part of that cylinder. So I've been to meetings where people have talked about imposing the anterior bowing of the mitral valve with rings. You don't need to. It will always do that itself. And any ring you place will distort that natural bowing of the outflow tract. The commissure, now Anderson and Becker and others talk about the commissure being the complete meeting between the anterior and the mural leaflet. It's like your lips. You have commissures here as well. We talk about these as being the commissures. And what I want to draw to your attention here is the fact that something you all know, the commissure does not reach the annulus. And there's a very good reason for that in the natural function of the valve. Before we get to that, let's talk a little bit about leaflet structure. The aortic leaflet is a D shape, and it has a smaller surface area than the mural leaflet, which is C-shaped. If you work it out, it just happens to be the way it is. The mural leaflet has these, for want of a better word, clefts within it, but the clefts never extend for more than a third or to 50% of the depth of the leaflet. This is how they normally look. And if we've just looked at 100 normal mitral valves, patients being examined with echocardiography for other reasons, and this is what we find. We do not find deep clefts. This is the abnormal, should be the abnormal if this will work, the abnormal situation, what we see commonly when we operate on patients with P2 prolapse. There's often a cleft to the annulus on either side of the prolapsing portion, to the extent that some of the original Club Mitrals I went to with Alain Carpentier, there were great discussions what to do with a little bit of leaflet left on the side when you've done your quadrangular resection. This is very, very common. If it's not on both sides, there's another abnormality that obtends that I'll show you in a moment. Why do I fit in a picture of a lady with a pleated dress? Well, the reason is that these normal clefts act like pleats. We were designed to be able to respond when we see a saber-toothed tiger, to go from a standstill to a sprint very quickly. And in doing so, rather like a Ferrari Formula 1 engine, we can rev very quickly, we can open the orifice, we can open the throttle, and get maximum throw through the valve. And the blood flow through an athlete's valve at full stretch at the 100 meters is greater than the surface area of the two leaflets when they're closed. And that's part of the normal functional variance. And to do that, these pleats allow this valve to open as a cylinder, not as a D shape that the natural structure of the valve imposes upon it. And that's exactly what the pleated skirt does for the lady. She can swing her legs freely. So it's just reproduced in nature in another way. Now, when we see these patients, the functional abnormalities, there's the normal cleft. This is what we commonly see. And the effect of that is to actually load these portions of the valve. The commissure I mentioned earlier does not reach the annulus. There is a load-sharing area. The mitral valve in systole is a force field. And we'll come on to that with the cords in a moment. It's a force field. It's a load-bearing surface. And it shares its energy around the whole of the valve. If you interrupt that force field with these clefts, then you have abnormal loading and stretching of the valve, which is what you see in the P2 prolapse. Now, I put to you that these are actually congenital lesions. This is not a myxomatous degenerative disease. The myxomatous degeneration is a response to 40 years of stress with abnormal loading conditions. And if you ask pathologists where else they see myxomatous disease, they'll tell you around knee joints and other points of trauma in athletes and so forth. Quickly moving on to the papillary muscles, this is the standard arrangement with two substantive groups of papillary muscles, anterolateral and posteromedial. But you find many patients with mitral regurgitations have these multiple fine papillary muscle heads, usually in the infromedial portion where the papillary muscle is not one structure like this. Normally they should be horseshoe like this, but you will find that the posterior inferior is commonly broken up into multiple heads like this. And often when you look inside some of the Barlows as well, you'll find the caudal length is extremely short. The papillary muscles are very close to the underside of the leaflet, and they're multiple and may go almost directly into the ventricle. This is again a form of congenital abnormality. Sorry, this is not working very well. And this is just to show you again the primary cords. Here we have the primary cords going to the anterior leaflet, the secondary cords, this is on the underside, going into the so-called rough zone, which causes the crimping on the atrial side, which gives you the rough zone, and then the strut cords, which give you the support at the base of the ventricle. Now, if you have abnormal support, you will have this force distribution I was telling you about, which causes leaflet stretch. So the primary cords restrain leaflet edges to prevent prolapse. They're rather like the guy ropes in a tent. When the ventricle starts to contract, the primary cords stop the leaflets prolapsing. And if you look in Barlow's, where they're all prolapsing, you'll see the whole valve everts and the whole atrial wall and ventricular complex move outwards. The secondary cords, these are the load-bearing cords. If you go inside Gaudi's Cathedral in Barcelona, or you go inside King's College Chapel, look up. You see this wonderful arcading of stone. It's beautiful, but it's there for a reason. It's load sharing, and that's exactly what the mitral does. And the tertiary cords are tensioning struts throughout the cardiac cycle. They're like tie rods in an engineering sense. So here, primary cords, the secondary powerful cords, and the tertiary strut cords, as you can see in that position. And from the other view, here we have these wonderful arcading patterns of the secondary cords, spreading the load on this valve which closes the highest pressure in the heart. Note where you have these deep clefts, and you see this in the mitral with a prolapse portion, the primary cords go all the way out to the depths of the clefts. So again, this is a congenital lesion. The valve stopped growing at some point in its life, and I'll illustrate that in a moment. This is just to make that point again. You see the cords if you look. Now, one of the luxuries when you do a lot of mitral valve surgery is you're pretty confident you're going to be able to do this, and you can do it in a short time. So you can sit back and have what I call my golden 5 minutes and just look and play with the valve. And you learn such a lot from doing that. And it alters the way you approach the valve. Here again, this is actually an ox heart, very big papillary muscles, but it really emphasizes this arcading and structural strength of the secondary cords, which Gaudi so beautifully reproduced in his cathedral. You see it in other walks of life in the hip bone, these wonderful stress lines that convey the weight of your body through the head of the femur down into the femoral shaft. And there again, just to make that point. So just think about that when you're looking at the mitral valve. Here is the tertiary cords, the basal cords inserting into the base of the valve, right in the ventricular wall there. These are part of the ventricular support in the non-compacted part of the myocardium. So let's think a little bit about the dysfunctional valve before I finish. Could what we refer to as degenerative disease be the result of malformation? Well, just remember how this is made. This is an immensely complex structure. I'll bet you we could take every one of us in this room, and if we could assess totally our mitral valves, you could be mapped as you could with your retinal mapping when you go through the iris at Heathrow. We're all so different. The papillary muscles form and the separation of these structural columns of muscle, and the growth of the AV cushions is like this from the base of the atrioventricular junction. And you won't be surprised to know that our knowledge about this is absolutely incomplete. Recently, talking to Bob Anderson and others, we still don't have detailed knowledge of this valve. But you think about the complexity of the deformity. It's not unusual to think that up to 15, 20, maybe higher percent of patients have a malformed valve. And this is the sort of thing I'm thinking of. And if you look at this, this is one of my drawings taken from an embryological drawing. It looks a bit like a Barlow's, doesn't it? And in fact, that's what we're seeing in the congenital formation. So distortion and coaptation is the last thing I want to talk about. And don't forget the atrium and the impact of chronic AF. Type 1 MR data I just recently mentioned to you. The loss of coaptation through caudal elongation and rupture and ventricular dilatation. This is a classic Barlow's prolapsing valve, and you see how the whole orchestration of the base of the heart has changed. The base moves out. People don't talk about this. Even the cardiologists don't talk about it, but it's in your face. The whole ventricle portion moves out. Once you've repaired that valve, the whole dynamic changes. The valve moves down into the ventricle, and the base once again moves in, because you've restored the dynamics of the valve, and it happens instantly. So, a beautiful structure. We partly understand it. It's fun to work with, but do look and look and look at the structure before you start to alter it in surgery. Thank you.